The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. And you know, Paul, they could probably see us if they're watching this on YouTube. This must be scary for them.
How exciting for them. That's lovely.
Tonight on the show, we are talking, this is an update on lipids. Paul, we're talking so much new ground tonight. My head is still spinning. We're talking about a whole bunch of new cholesterol-lowering medications and some just sort of more, we'll call this advanced lipid management with returning guest, Dr. Erin Michos. She is a cardiologist and a lipid expert. We have a great co-host who you can see if you're watching the video, but if you're listening, then wait a second. You'll hear his beautiful voice in a second.
His dulcet baritone.
So, Paul, I have a great pun for you, which I'm excited to get to. But first, can you tell the audience what is it that we do on the Curbsiders?
Sure. Happy to, Matt, as per usual. We are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. We are, as you mentioned, joined by, you know him, you love him. He doesn't need an introduction, but it is Chris, the True Man Shoe. Chris, how are you?
Great, man. Great. It's been awesome. It's been a while since I've been on the show.
So, Chris, can you tell us, maybe tease for the audience more? I talked a little bit about it, but what are we going to get to on this episode? And then can you tell them about our guest?
Yeah. So our guest we just had a wonderful conversation with Dr. Erin Michos. You might remember her from our episode 191 from, a little more than 2 years ago. She is an associate professor in the Division of Cardiology at Johns Hopkins School of Medicine with a joint appointment in epidemiology at the Johns Hopkins Bloomberg School of Public Health. She is the Associate Director of Preventative Cardiology. Dr. Michos is an internationally known expert in preventative cardiology and women's health, having authored more than 570 publications and 11 book chapters. Her research involves cardio-obstetrics and women's cardiovascular health, coronary artery calcium, inflammation, other biomarkers, lipids, and diabetes and cardiometabolic disease. She's the co-editor-in-chief of the American Journal of Preventive Cardiology and associate editor for Circulation, a member of the board of directors for the American Society of Preventive Cardiology, and a member of the American College of Cardiology Prevention Leadership Council. She's also a member of the ACC's Clinical Quality Approval Committee, and Dr. Michos has also held several leadership positions within the American Heart Association, including being a member of the AHA funding committee. Today, she's going to school us in advanced management of lipids, including new treatments for patients with elevated Lp(a), all the different types of PCSK9 inhibitors, and how they will fit into your LDL lowering armamentarium. I don't believe I wrote that in the script. I can't even say it.
And Paul, I wanted to tell you, I'm a big fan of New York, but you'll never guess my favorite borough because the people there have the best cholesterol levels.
I feel like I should be able to figure this out by context clues, but why don't you tell me?
Paul, it's Staten Island.
Oh, that's actually pretty good.
There we go.
Thanks to 7hilariouscholesterolpuns.com for setting me up for that one.
I'm sorry, Chris, what was the first thing that you played there by accident? What do we...
This is the spooky...
That feels better, actually.
All right. A reminder that this and most episodes will be available for free CME credit for all health professionals through VCU Health at curbsiders.vcuhealth.org. Dr. Michos did disclose that she has acted as an advisor to AstraZeneca, Bayer, Boehringer Ingelheim, Esperion, Novartis, Novo Nordisk, Pfizer, and we will say that we did discuss a balanced range of therapeutic options on this episode. We did not use trade names, and that's it. Enjoy the discussion. Erin, welcome back to the show. Thank you so much for joining us again. This was kind of set up on Twitter because we reposted your prior episode, and now you're back. Remind the audience a little bit about yourself and maybe remind them of a hobby or interest you have outside of medicine.
Great. Well, thank you so much for having me back. So I'm Erin Michos. I'm a preventive cardiologist at Johns Hopkins who has an interest in women's health and also lipids. I'm a mother of a high school student, so I'm feeling old. And my hobby is I like to run, although I'm pretty slow at it and not talented at it. But we've talked about before, I've been trying to do a marathon in every single state, so I'm working towards that goal.
Paul, are you in that club of a runner who's not talented and slow? I think you've told me use that same phrasing maybe.
All correct. And I'm pretty close to doing a marathon every state. I have like 49-ish to go. But I feel like it's just a matter of time before I catch up to you.
Paul, I believe in you. You know
I appreciate that, Matt.
Yeah. Well, we have a lot to get to tonight, but we have Chew Man with us. So, Chew Man, did you want to give a pick of the week before you read us a case from Kashlak?
Yeah, I just want to remind people that we have this brand new series in the Curbsiders called the Curbsiders Addiction Medicine Series, and Dr. Carolyn Chan has been doing a fantastic job with it. And I recently listened to their buprenorphine episode with the outpatient setting, and it was fantastic. And as a provider who does outpatient MAT and MOUD, it was a great primer for anyone who's really interested in it. So I really encourage people to check it out.
Yeah, so I think residency programs should just put that on their curriculum as required listening. But I'm definitely biased, but I am very proud of Carolyn and the whole team. They're just doing a fantastic job.
Yeah, it's all killer, no filler, and every guest they have is just top tier, like hugely influential in the field and just doing amazing work. So like it's a genuine pleasure to listen. I don't listen to medical podcasts, but this is one I actually listen to, even the ones that I'm not on. So yeah, great stuff.
Well, let's get to a case from Kashlak because we are going to geek out on some lipids tonight. There's a lot of new stuff for us to learn about. Chris, do you want to read us the case?
Yeah. So we have a 45-year-old self-identified male patient who presents to the primary care clinic here at the Kashlak State for general follow-up. He is only on hydrochlorothiazide for a well-controlled hypertension, and he works a desk job and really isn't really physically active other than playing a little Beat Saber on his VR headset once in a while.
I don't know what that is.
Totally typical of my patients. Really just
So he got pre-appointment labs because we're being really good about getting our patients to do this so we can talk about him during his appointment. And his labs include a non-fasting lipid panel with a total cholesterol of 242, an HDL of 51, a triglyceride of 114, and a calculated LDL of 168. We threw it through the ASCVD risk estimator calculator, which gave us a 10-year risk of 8.7%. And his only other pertinent history is that his father had an MI at age 47. So, I just want to make sure that our listeners go back, listen to episode 191, which came out, like 2.5 years ago, where we discussed like a lot of the ACC-HA, like 2018 updates, to just really get a good background on this. But to start the discussion here, I just want you, whether you could talk to our listeners and remind us what are sort of the different risk categories in assessing primary prevention.
Right. So there's 4 groups that we've identified as statin benefit groups. So in primary prevention, individuals with LDLs above 190, this group is enriched with those who have familial hypocholesterolemia, so they would benefit from a high-intensity statin. Patients with diabetes over the age of 40 should be at least on a moderate-intensity statin. And then if they have risk factors, high-intensity statin. And then individuals who are above 20% 10-year risk score, those also are an indication for high-intensity statin. And then individuals, again, as part of a risk discussion, who we think are at high enough risk after a patient-clinician risk discussion. So this is, you start with the pooled cohort equations as a starting point, and then consider these risk-enhancing factors. And we'll talk about this patient already has several of them. But if those are present, that would also favor the initiation of statins. And then sometimes even after estimating the 10-year risk score and considering risk-enhancing factors, there can still be uncertainty about an individual's risk. And in those cases, a coronary artery calcium score can be performed to help refine risk a little better and guide shared decision-making about preventive therapies like statins and possibly aspirin.
I guess you mentioned the coronary calcium score. I wanted to see, My experience, and Paul, I'm interested to hear yours, is the patients often have to pay out of pocket something like $200 or $300. So I've had a couple of patients take me up on that. But in your case, Paul, is that happening as well?
It's at my area of cash, like not quite so pricey, but still out of pocket so far as I know. And it's something that I commonly see done.
Yeah. Erin, is there a good way to get these covered or?
I mean, I don't know if you tried recently, but it's so much different now, so much easier than it was 5 to 10 years ago, because coronary calcium score is in the guidelines now as a 2A indication for just like these patients where there is some uncertainty about risk and the net benefit of preventive therapy like statins. And so it's in the guidelines as 2A indication. So most insurances cover it. But even if it's not covered, at least at my institution, it's $75 out of pocket. I mean, it's really a cheap test, and certainly much cheaper than many, prescription medications or many other tests that we do for cardiology risk assessment. So I think the information that you get is very valuable. But I have not had a patient pay out of pocket for quite a long time. Sometimes it still happens, but it's been so much infrequent now compared to 5 years ago.
Yeah. I think the interesting thing about coronary CAC scores to me is if it's a non-zero score, okay, it's probably easier to convince the patient to be more aggressive about therapy. But if it's a 0 score and they have risk factors like they're 45, like this guy, have an LDL that's elevated, have a family history, maybe that's great news and maybe we should be more aggressive so nothing happens. Like, once they have calcium. So like we were talking in pre-recording about this idea of like cholesterol years. So can you talk how you talk to patients with a non-zero CAC score, but who you're still like, maybe they have diabetes or they smoke or they have a strong family history? Like, how do you handle that discussion?
Well, so first of all, this patient already has 2 risk-enhancing factors. He is 45. He has an LDL above 160 and a family history of myocardial infarction. So I would already favor treating him with a statin. The coronary calcium score is when there is risk uncertainty. But getting back to the cholesterol years, absolutely. It's not just the magnitude of elevation of LDL, but the duration of exposure, akin to, we think about pack years of smoking. So if there's this theoretical threshold, some have said about 5,000 milligrams per deciliters, a milligram per deciliter years, that, individuals who have, high cholesterol from birth, such as those who have genetic FH, they cross over this threshold, early in life. On the other hand, individuals who have lifelong low LDL from either favorable genetics, and healthy lifestyle, they may never cross over this threshold for the onset of clinical ASCVD. But it's important to keep in mind that even individuals who have mild to moderately elevated LDL, if they've been at that long enough, they will also cross over the threshold of clinical ASCVD, earlier in life compared to their counterparts that have lower LDL. And so prevention is really best implemented when it's implemented early. I mean, it's never too late, but it's better to implement early. These 10-year risk cut points can really underestimate risk in, younger adults. I mean, this patient at age 45, he might be at low risk over the next 10 years. But, in a 45-year-old, I'm not wanting to keep him just healthy for the next 10 years. I'm thinking about the next 40 years. And, his arteries have already been marinating in this high LDL of 160 for all these years. And I would treat him now. You wouldn't not treat a 45-year-old with a systolic blood pressure of 160 just because he's only 45 and, his 10-year risk is not above a certain threshold. We would want to avoid further vascular damage. And so, I would strongly recommend treating him now. But sometimes patients are reluctant for whatever reason. And there is, data suggests that knowledge of one's calcium scores can be an effective strategy for someone to, implement statin therapy. And there's already preliminary data from, the CoreCal Vanguard study from Intermountain Health show when they randomized individuals to a risk factor-based approach versus a coronary calcium-based approach. At 1 year, those with a coronary calcium-based approach were more likely to be on a statin and have their LDL and other risk factors controlled. So seeing is believing, and I think that's really helpful. But, to get back to your point about a 0 calcium score, that should not supersede clinical judgment. So if a patient's actually having symptoms of ischemic heart disease, you wouldn't necessarily be reassured about a 0 score. So I put, less stock in a 0 score in a younger person. They might not have had time to calcify their plaque yet, but it is reassuring, in an older adult if their score is still 0.
So one question I have.
Go ahead.
Sorry, Paul. I was just going to ask a little bit about, we talked about CAC score a couple times now, and I've definitely done this with a couple of my patients. In my neck of woods, it's $99 out of pocket if insurance doesn't pay for it. So I often get these non-zero CAC scores. And so they're not super high. It's not like over 100 or whatnot. But then I also, in my report, there's a MESA, the MESA score is also calculated and gives me sort of like this estimated arterial age. And I was just wondering, what's the best way to counsel patients on what that means? So, I've had, 50, 60-year-old who had, so I say I had a 60-year-old and they did a CAC score and they said their estimated arterial age is 40 or something like that. I don't know what to say about that. I was like, okay, I guess you're younger than what you're supposed to be at, but I also think that you still are at risk. How do you counsel patients about that and how do you approach it?
Well, any non-zero score is associated with risk, in a graded fashion, but even scores 1 to 10 are associated with, increased events compared to those with a 0 score. So the guidelines had said, a statin is recommended if the calcium score is above 100, but it can be considered for any non-zero score. So that's how I practice. Certainly any non-zero score, they have plaque, they have disease. So I start a statin. But particularly in younger adults, keep in mind that, for example, a 50-year-old woman should have a zero calcium score. So if her calcium score is 10, that's above the 75th percentile for her age and gender. So statins are also recommended for calcium scores above the 75th percentile. So I also benchmark it to age, gender, percentile. But this patient has multiple risk-enhancing factors, and we can talk about whether we'd measure some additional risk-enhancing factors, here in a minute with his family history. I think we'll want to get into lipoprotein A. But again, I would already recommend starting a statin in him. And if he came to me and already had a 0 calcium score, I would say, that's great. Let's keep your arteries clean. Your father had a heart attack at a young age. Your LDL is above 160. I'd want to start a statin to, why wait till there's disease? I would start treatment now for prevention.
Yeah, this leads
now,
into...
this is different than someone who is, very low risk and has no risk factors. But I think this particular case patient, has a high lifetime risk.
That makes a great deal of sense. I guess the point that I was going to make, and this might transition into sort of when should we go hunting for additional risk-enhancing factors, is it would be very uncommon for me to see a patient in my practice whose 10-year calculated risk is greater than 7.5% that doesn't already have some pre-existing risk-enhancing factor, which is maybe why I'm not doing a whole lot of calcium scoring, because I feel like I'm already kind of convinced this person might need statin therapy. But I guess what I'd be curious to hear from you, or if you could at least remind us, sort of when should we start chasing down some of those other factors? So, for instance, I think we mentioned Lp(a) a couple of times. When, for instance, would you check that? And sort of, can you just remind us the utility of that and how we should be using it?
Yeah, so many of the risk-enhancing factors you already know from their clinical history. For women, premature menopause or history of preeclampsia, if they have inflammatory conditions like rheumatoid arthritis or, lupus, if they have chronic kidney disease, if they have a persistently elevated triglyceride, a non-fasting triglyceride above 175, these are many factors that you already know about. Now, I do check a lipoprotein A in all of my patients. I'm more in line with sort of the European guidelines, just because that the field is moving, and we may have new therapy to potentially offer those individuals, beyond statin therapy. And so in order, when those drugs, if they turn out to be successful in trials, we'd want to know who to treat, and we won't know who's elevated unless we measure it. So in this patient, I would measure lipoprotein A, particularly because he has a family history. Lipoprotein A, is highly genetic. About 90% of it is related to the lipoprotein gene. So it's highly heritable and it runs in families. It's an LDL-like particle, so it has an apoB moiety, like all the other bad atherogenic lipoproteins, including LDL. But it also has this apolipoprotein A moiety, and that's what distinguishes it from LDL. But so why do we care? Why do we measure it in this person and in other patients? Well, it's pro-atherogenic, it's pro-inflammatory, and it's pro-thrombotic, partly because I think it can carry oxidized phospholipids. But lots of evidence now from epidemiology studies and meta-analysis and Mendelian randomization and GWAS studies, as well as analyses of clinical trials, have really indicated a causal role of lipoprotein A with ASCVD and also aortic stenosis. And it's pretty common. There's, we can get into, there's important to know the different lab differences between whether it's measured in mass by milligram per deciliter or molar, which is nanomils per liter. It's important to know the difference because, the cut points are different based on the assay. So it's important consideration when you're looking at these numbers to make sure you know what units you're talking about. But using the mass units of a lipoprotein A above 50 milligrams per deciliter, it's estimated that 1.4 billion individuals worldwide have elevated lipoprotein A, which is about 20 to 25% of the global population, or essentially that translates to 1 in 5 individuals. So that's a lot. And it's been shown to increase risk, though, even in a linear fashion, even though I've mentioned these thresholds for elevated. And even among individuals who have very low LDL, like in the Copenhagen study about individuals who had LDLs less than 70, elevated lipoprotein A is still a risk factor in those individuals. So I think it's important to know and why I would measure it in this patient, because it would be one more risk enhancing factor that certainly would favor more intensive treatment with his other risk factors, but also with statins, even though statins don't lower lipoprotein A, but also because, we have emerging therapies that are in trials right now, which we can talk about.
I want to try to recap just a little bit. Lp(a), which we talked about last time, you said because it's highly heritable, you like to check it at least one time in people, in everybody. And we think this has a causal role in badness like atherosclerosis, and you said aortic stenosis. And being on a statin doesn't necessarily affect the levels, so it's not really something you're yet tracking over time. But we're going to talk about some therapeutic targets for this, where I imagine tracking Lp(a) might be something that's going to be done. And then you said if your lab is reporting milligrams per deciliter, that greater than 50 is where that seems to be one of the cut points where above that level people are at higher risk.
Right. So a couple things there. So even though lipoprotein A is primarily genetically determined, and it's generally non-responsive to conventional lifestyle changes, such as a low-fat diet or weight loss or exercise, there are some things that can increase levels. So in women, for example, lipoprotein A levels increase after menopause, after age 50. So that kind of challenges the notion of only measuring it sort of once in a lifetime, because it may become elevated in women, later in life. Other chronic kidney disease is associated with elevated levels. So if somebody, developed kidney disease and they didn't have it before, that can affect their levels. And acute inflammatory conditions. To be clear, who to measure lipoprotein A in, it is some differences among guidelines, as this is sort of an emerging field. In the U.S. guidelines, the AHA-ACC have said to measure it, consider measuring in people who have a personal history of ASCVD or a family history of ASCVD. The NLA, the National Lipid Association, adds to that, saying, in addition to those, if someone has an LDL that seems to be refractory or only partially responsive to therapy, measuring lipoprotein A, because that might be contributing to the, lack of response in LDL lowering, because they have, lipoprotein A driving their LDL concentration. They also recommend it in measuring patients who have calcific aortic valve disease. But the European guidelines, which is I'm kind of in line with, they recommending it measuring it at least once in all adults, measuring it at least once, because you want to identify those that have the very, very high levels that may have a risk similar to familial hypercholesterolemia patients. And then for the mass versus molar issue, so yes, know what your labs. So when you're reading a study in the literature, they'll report both values, and it's a little bit confusing. And the problem is that there's no direct conversion, and the guidelines don't really recommend any direct conversion from milligrams per deciliter to nanomoles per liter, because this gets back to the issue of the heterogeneity and the ApoA isoforms. So when you're talking about molar units, that's sort of more representation of the total number of particles in your blood as opposed to mass. So there's really no direct conversion factors. But if you want to do the back of the end, like really quick, rough estimate, one says if you multiply your milligrams per deciliter by 2 or 2.5, that's sort of a best guess for your conversion of nanomoles per liter. But it's really not a simple conversion factor.
Well, let's get into talking about this, Chris. So what's happening with our patient and their Lp(a)? Did we check it?
Yeah, so I think we decided to check the Lp(a) and it was elevated. And I didn't actually put in any numbers because I wasn't sure at the time. I was like, I couldn't figure it out. So,
let's say it's 120.
Yeah.
Let's throw that. Is that realistic?
I mean, so can people be like borderline high in Lp(a), or is there, I think you said there were sort of cutoffs based on, are there people who can sort of sit in the middle, and does that make a difference?
So risk is continuous, just like LDL, and our guidelines have some cut points for LDL, but, risk is continuous. And so, there's, higher is associated with greater risk. But the guidelines, U.S. guidelines, have put above 50 milligrams per deciliter as what's considered a risk-enhancing factor. But interpretation of the value really is in the context of a person's absolute CV risk. So, in someone who's otherwise low risk, you really focus on, lifestyle, and really optimizing all their other risk factors, having personalized recommendations for their LDL and their blood pressure and treating everything else. Higher risk patients, especially those who have ASCVD and progression of their ASCVD, we definitely want to even think about more intensive treatment. So, as I mentioned, statins don't lower, and they may even increase lipoprotein, but we still use statin therapy primarily because, there's overwhelming evidence that statins reduce major adverse vascular events. So that's the background, to lower the overall risk of cardiovascular events, even though statins don't lower lipoprotein. Now, patients who have very, very high levels, who have progressive cardiovascular disease, and this is why, risk really matters, lipoprotein apheresis is an option for these very high levels. Now, if they have ASCVD, both PCSK9 inhibitor monoclonal antibodies, as well as inclisiran, this new agent we can talk about, it's a small interfering RNA against PCSK9. Those agents do lower lipoprotein about 20 to 25%. So it is a good option if you have a high-risk patient who has ASCVD or has FH who needs additional LDL lowering and also has elevated lipoprotein. This is a good agent to put them on PCSK9 inhibitors. We know with the note that PCSK9 inhibitors are not FDA approved specifically for lipoprotein lowering. But if the patient has other reasons, if they're a candidate for PCSK9 for other reasons, then, that's used in those patients. And that's why it's so helpful sometimes to measure lipoprotein, because I might go to earlier use of PCSK9 if I know that's elevated. A few other things that come up a lot with patients. Even though niacin can lower lipoprotein, we don't recommend that given the lack of clinical benefit in 2 outcome trials. Estrogen can lower lipoprotein as well, but hormone replacement therapy is not recommended for the sole purpose of lipoprotein lowering because it also hasn't been demonstrated to reduce outcomes. And then current data doesn't really support targeting aspirin specifically based on lipoprotein A, although I tend to use it based on a sub-analysis of the Women's Health Study that showed that women who had the gene for elevated lipoprotein A seem to benefit more for aspirin. But that really hasn't been proven yet in trials. So that's what we have today, but it's a really exciting time because now there's some emerging therapies that are specifically targeting lipoprotein A, and we might have options for patients that we didn't have before.
Chris, did you have a...
Yeah, right before we go into this new therapy, there's one more medication I wanted to make sure I ask about. So, you said that we're really targeting, if we need to, we're really targeting LDL lowering in general and sort of utilizing our sort of bag to do that. We know that ezetimibe has been shown from the IMPROVE-IT trial to really as a great adjunct to high intensity statin therapy that I think many of us use in our clinical settings before we go to PCSK9 inhibitors. Is that something that should be thought about, or are we doing high dose statin and then, especially if the Lp(a), we're going to be trying to get to that PCSK9 inhibitor outside of some of these newer medicines?
Yeah, so ezetimibe and bempedoic acid don't lower lipoprotein A, but they certainly lower LDL, and we absolutely, use those agents and appropriate candidates who need additional LDL lowering. And LDL still remains the primary target, so we definitely want to lower LDL first. But I think it's important to kind of understand the reason why I measure lipoprotein A is that on a standard test, if you just get a standard lipid panel and you get an LDL, you don't know how much of that is due to lipoprotein a. And so some patients are not responding with their LDL lowering because they have elevated lipoprotein A. For example, you might have a patient whose LDL is down to less than 70. You still should measure, if they're a high-risk ASCVD patient, measure lipoprotein A in those individuals, because two people with relatively low LDL, less than 70, could have very different heart disease risk. We think that, for example, on average, every 10 milligram per deciliter of lipoprotein A in the blood increases LDL by about 3 to 4 milligrams per deciliter. So if your lipoprotein A level is low, its impact on LDL is minimal. So if you have a person who has an LDL of 70 but a lipoprotein A of 10, that means like only 3% of their LDL is due to lipoprotein A. But on the other hand, if their LDL is 70 and their lipoprotein A is 150, almost 2/3 of their LDL could be from lipoprotein A and have residual risk. And what does this matter? Well, this matters because we may use different therapies to potentially target this residual risk if it's being driven by elevated lipoprotein A.
And I just wanted to point out, you mentioned LDL is still our primary target. And earlier in this episode, you said we just have overwhelming evidence that essentially lowering LDL, we can lower cardiovascular risk. And I think we're going to get into this with talking about pelacarsen, which is one of the Lp(a) directed therapies. Do we have outcomes yet? Do we have a convincing model to say that Lp(a), if we lower it, that we're going to lower risk? I remember several years ago, we tried to raise HDL. We thought it was going to work, and that didn't end up working. The targeted therapies there. So, do you think? Are you thinking that this is definitely going to work, or do we? How much do we know so far?
Yes, so we don't have that outcome data yet. I think somewhat the difference, and this is why there are no approved therapies for lipoprotein A yet. This is all trial data. But the difference is that we have a lot of genetic studies that have really shown that there's a causal role with lipoprotein A, where we were never able to demonstrate a causal role from HDL. That Mendelian randomization studies have not found HDL to be a causal factor. It's associated with risk, but it's not a causal factor. So because of that, it does seem to be likely that reduction in lipoprotein A would reduce risk. We need to test this in trials because we really don't know how much, for LDL, we know pretty linearly that, for every 1 millimole per liter or 39 milligrams per deciliter that, we can reduce major adverse cardiovascular events by 20 to 30%. And so we really see this consistently, but we don't really know how much lowering lipoprotein A really translates into reducing events. In some modeling data suggests that you actually might need large reductions of lipoprotein A, lowering it by more than 50 to 100 milligrams per deciliter to really have a meaningful reduction in ASCVD events in a short term, like over the period of a 5-year trial. So how much lipoprotein A needs to be lowered to produce a clinically meaningful benefit remains uncertain, and that's why we await the results for these the trials that are ongoing.
Yeah, so I guess now's a good time. Yeah. Chris, where do you want to take it?
I was just going to ask then, sort of comes back to at the beginning of the discussion, if we see a medication like pelacarsen come to market and be used widespread, do you think that then we'll be routinely measuring Lp(a) for reduction like we do for our LDLs?
So the agent that's the farthest along in trials, it's already in phase 3 cardiovascular outcome trials, is pelacarsen. So this is the antisense oligonucleotide targeting lipoprotein A, and in phase 2 trials was shown to reduce lipoprotein A by 80%. So I mentioned before that PCSK9 monoclonal antibodies only lowered lipoprotein A by 25%. And this lowered lipoprotein A by, 80% or more. So that's very exciting. But we really need to know, what does that translate to? Does that actually reduce cardiovascular events? And that's being studied right now in a very large cardiovascular outcome trial, thousands of patients. It's called the Horizon trial. And hopefully we'll have some results from that by, 2024, 2025. But like all cardiovascular outcome trials, they're several years ongoing just to have events. And that trial is enrolling patients who have ASCVD and elevated lipoprotein A. Another agent that's not too far behind in development is olpasiran. Now, this is a small interfering RNA that's also targeting the messenger RNA for lipoprotein A. Earlier this spring, it was announced, I don't think it's published yet, but the top line results from the OCEAN study, which is a phase 2 trial that enrolled, 281 individuals, so small numbers because it's a phase 2. But in this phase 2 trial, this agent also lowered lipoprotein A by 90%. So again, very effective. And in this, smaller phase 2 trial, there was no safety concerns.
Better name than Horizon as well, Paul.
Yeah. Well, this is
Ocean has been used before. Yeah, I was just thinking, I cannot believe that they have not crossed it off the list yet. It's very exciting.
Yeah. So this was Ocean Dose. This was phase 2, where Horizon was the, is for pelacarsen is a phase 3. But you may have read about the Apollo trial, which was published in JAMA in April. Now, this was only a phase 1 trial, so we're now talking very small numbers, 32 participants. But this is another small interfering RNA against lipoprotein A, SLN 360. And in the Apollo trial, which was published earlier this year, of these 32 participants, this agent also lowered lipoprotein A by about 90% compared to placebo. So these drugs seem to, lower the target, lipoprotein A, and in phase 1, phase 2 trials seem to be safe, but we really need the larger outcome trials before there would be any FDA indication or before they would be available for patients. But it's important to know these are coming down the pipeline because we can start by finding out which of our patients have elevated lipoprotein A.
I was going to ask about, just to confirm, pelacarsen once a month injection is what it seems like it's going to be in the Horizon trial. Is that right? I guess. Yeah.
And then, so all of these are subcutaneous injections, and they've been looking at different, dose finding, like in the Ocean trial as well. They compared different doses, and so we'll see what turns out to pan out to be the best.
Yeah. So it's seeming, because these are subcutaneous, because these are brand new, I'm guessing that at least in the next 10 years or 5 or 10 years, these are mostly going to be limited to very high risk patients, probably in specialty clinics that have like known, like really strong risk factors. I mean, like our 45-year-old that we started with who hasn't had any events yet, even with a really high, I think we gave LP little a of 120. Do you think this would be someone that would qualify anytime in the near future?
Well, these drugs are not available, but he may, with his family history and his elevated LDL, I would have to examine him, and but he may have some risk factors for FH, and you certainly could consider genetic testing in him. But if he had an elevated Lp(a), or certainly if he had evidence of ASCVD, sometimes if I can't control their LDL on statins and ezetimibe, I might use a PCSK9 inhibitor in these patients. So I have been able to get PCSK9 inhibitors approved in patients with very high calcium scores, above 300, a calcium score above 300. The event rate is fairly similar to a stable secondary prevention population. So some of my patients who haven't had an event yet, but they have evidence of significant subclinical disease, have evidence of, clinical, evidence by imaging that they have atherosclerosis. I have been able to get PCSK9 inhibitors approved, targeting their LDL, but knowing that, it has some effect on their Lipoprotein.
Well, Chris, I think we should move on the case, and because we still have some more new agents to talk about.
Yeah. And so now we're talking.
Some that are already approved. The ones I was talking about, the ones weren't approved yet.
So we've already sort of transitioned a little bit into the PCSK9 inhibitor discussion. But so we're taking our patient. He has an LDL. Say he has an LDL now of 250, and based on the 2018 guidelines, we need to shoot for a really low LDL. Our guidelines, these guidelines say less than 100. So after we start him on maximum dose statin therapy, his LDL is still 115, and we even added some ezetimibe just for good measure. We're looking at PCSK9 inhibitors as our next step. Can you sort of give us a little update from the last time we talked? We did talk a little bit during that last episode about PCSK9 inhibitors, but I think there have been quite a few new versions of this have come out, including other types of monoclonal antibodies and some other ways in which these drugs are targeted. Is that correct?
Yeah, so, if he likely with an LDL of 250 has his family history of his father having an MI, he'd have FH. And so if we were not able to get his LDL down enough, we probably wouldn't be able to. With high-intensity statins, you'd have about a 50% lowering of LDL, and then with ezetimibe, another about 18% lowering. So we wouldn't be able to get to target likely with that. So I would move early with combination therapy. And I just want to make the plug that if you know where you need to go and where you're starting, I think we waste too much time with sequential therapy. Just like with blood pressure, you start combination therapy early. And I would strongly recommend early onboarding of combination therapy, trying to get patients to goal. Because, unlike blood pressure or diabetes, who has theoretical risk of, hypotension or hypoglycemia, there really is no risk of having, too low of LDL. So I would really onboard these early. So he would be, a great candidate for PCSK9 inhibitor. We have 2 monoclonal antibodies that are already FDA approved, evolocumab and alirocumab, and those both have clinical outcome data. So not only do they lower LDL, but they also reduce major adverse cardiovascular events by at least 15%. And there's data also showing, even a legacy effect from those trials that those that had, earlier treatment with the PCSK9 and had earlier lowering of LDL had, greater reduction than people who started the PCSK9 later after the trial is over. So earlier onboarding is definitely important. Now, the new kid on the block in this category, I mentioned a little bit earlier, is inclisiran. So it is a small interfering RNA that's targeted against PCSK9. I was talking earlier about small interfering RNAs targeting Lipoprotein. This one's targeting PCSK9. So the evolocumab and alirocumab are monoclonal antibodies targeting PCSK9, and this is preventing the synthesis of PCSK9. So this also has that GalNAc conjugation that really allows liver-specific binding. So what's the advantage of this is that it has a longer pharmacologic duration. After you do the initial injection and then once again at 3 months, then you go to every 6 months. It's been shown in the Orion trials to lower LDL about 50%, which is, considerably longer duration to lower this again for over 6 months compared to the monoclonal antibodies, which are given every 2 weeks. So this is FDA approved for patients with ASCVD or patients who have FH that haven't been able to get to LDL goal. Now, I will mention that we don't have the outcome trial yet for inclisiran. Orion 4 is the dedicated cardiovascular outcome trial, and it's currently examining this. But it did get FDA approved because, we know it lowers LDL, and, we have a really good sense of, lowering LDL should translate to benefit. So some of the unique things about this is that, so this was just FDA approved in December 2021, but the injections are meant to be given in a clinical setting. And so, so that the monoclonal antibodies patients give to themselves at home, but this is usually given in a clinic. And so different institutions and different practices have been trying to figure out how to sort of onboard it and, where to give it. Sometimes they're given at infusion centers or, given in the clinic itself or other locations. But it's sort of more of a buy and bill model where, a practice may buy the doses and then, then bill for each administration that they give.
Yeah, I think any of these injectables, I think they're just going to be, at least for the primary care offices, it's going to be a while. Like usually in my experience, these things are first given in specialty offices. I think our main role in the near term, Paul, tell me where your head's at with this. I think probably is going to be identifying who might benefit and referring to people like yourself that know what to do with these. But Paul, what are you thinking?
No, there's a handful of the folks that I have started on the PCSK9s kind of independently, and a lot of times the model does sort of look like what you're suggesting, where I send someone off with a specific question: hey, would this patient benefit from this agent, and sort of let them fight the good fight. I guess I had a question about the inclisiran specifically. I feel like when I see the PCSK9 inhibitors used, it's almost always in the setting of statin intolerance, not so much not achieving goals. So someone who has high risk or in secondary prevention land, but they just cannot take a statin and their cholesterol is not where it needs to be. That's typically where I see the PCSK9 inhibitors approved, or at least approved easily. I guess what I'm wondering in terms of the inclisiran, do we see that as a replacement for a statin therapy or as adjunctive therapy? Because the 50% reduction is actually not... I mean, it sounds like it's relatively comparable to a high-intensity statin. So would you continue a statin and give this to kind of give someone the extra push, or is this to do instead? Or I guess how are we using these medications with statin therapy is a question that I had.
Yeah. So first of all, the PCSK9 inhibitors are approved in ASCVD patients and patients who have FH as an adjunct to diet and statins for patients that remain with residual elevated LDL. So for some patients, the maximal tolerated statin is 0 statin. But the PCSK9 inhibitors are meant to be administered on a background of statins. In fact, both in the Fourier and the Odyssey outcome trials, which were the outcome trials with PCSK9 inhibitors, these were patients with ASCVD who were all on a background of statins. So, in clinical practice, our patients are often not at LDL goal because they're, they feel that they can't take a higher intensity statin for whatever reason. But, these are meant to be, added to statin therapy. So inclisiran, the same thing. Again, this is approved as, for patients that need additional LDL lowering who are high-risk patients with ASCVD or FH. And so generally, this would be added to a statin and to inclisiran, to ezetimibe and to the other therapy. You wouldn't use inclisiran with the monoclonal antibody PCSK9, but you would use it with a statin. Now, what is the advantage of, what would you use, which patients for inclisiran and which ones to use the monoclonal antibody PCSK9? I think this comes down to a shared decision-making with patients. So the advantage of inclisiran is that it's every 6 months. So for younger patients, the thought is it might really help with adherence, only one more time a year than a flu shot, and they could slash their LDL by 50%. And so definitely for patients who can't get to goal with their statin for whatever reason, this might be a good agent. With the caveat that, we don't have outcome trial yet data for inclisiran. It's coming. We do have outcome trial data for the monoclonal antibodies. So for patients who are already on monoclonal antibodies, I'm certainly not switching them if they're doing well with the injections. But when I have a patient who I need additional LDL lowering, I can talk to them about both options and take in patient preference, whether, between giving the office injection versus every 6 months versus them doing the self-injections at home every 2 weeks.
Yeah, so this is, I want to just try to recap here and make sure. So the first new agents we talked about were pelacarsen, which is an ASO. I'm not going to try to remember the whole antisense oligonucleotide. That's for lowering Lp(a), lowered it about 80%. And then there's this other one, olpasiran, which lowered Lp(a) about 90%. Those ones, we're waiting for them to be approved. We're waiting for the outcomes data there. Then we switched into this, for this patient with very high LDL, we're talking about, PCSK9 inhibitors. We do have outcomes data for them. We know they're very good at LDL lowering. So those are still in play, but they require, and patients can give them at home, but they have to inject them more frequently. Inclisiran is a newer agent that also has about 50% LDL lowering, can be combined with statins, and it would be given once every 6 months. And that may be, for some patients, more attractive if they aren't able to or don't want to give themselves injections at home. And we're expecting that the Orion trials with inclisiran are going to show reduction in MACE just the way all the other LDL lowering drugs have. Anything I'm missing there?
No, that was an excellent summary. And inclisiran also can lower lipoprotein by 18 to 26%. As well, which may have potentially some additive benefits, but it's FDA approved for its LDL lowering properties.
That would be great if it just becomes like a blockbuster that is just like better than all the, because it has both those mechanisms. It seems pretty attractive. Maybe somebody with really high both LDL and Lp(a), maybe it's would be a great one.
Well, the PCSK9 monoclonal antibodies also lower lipoprotein by 25%. Yeah. So that's what I was getting back to, why I measure it in patients, because if they're higher risk, they already have atherosclerosis or clinical events, I kind of would move quickly to the PCSK9 monoclonal antibodies if they have elevated LDL and elevated lipoprotein.
I forgot. You did say, I have that note, and this is how dense we have gone. There's been so much new information tonight. This is great, and we still have.
So it's statins, ezetimibe, and bempedoic acid don't lower lipoprotein, but the PCSK9 monoclonal antibodies and inclisiran do, but only by like 25%, which is why these new therapies that are still being studied and they're not approved, I'm just letting the audience know that they're out there being studied. Those can lower lipoprotein by 90% because they're, very specifically targeting the lipoprotein messenger RNA.
Now, you've actually brought up bempedoic acid a couple times now, and I sort of want to get into a little bit because I don't know what that is and how it differs from our other LDL lowering therapies. It's oral medicine, I think I know,
Chris,
right?
Can I tell Paul, these were the CLEAR trials, and Paul, they had cute names. There was Tranquility, Serenity, Harmony, and Wisdom, Paul. So I thought you would just love Paul. Paul's a big trial head, so he really likes that.
Well, just the name part, like the actual data, I'm less interested in. But yeah, the names of the trials, all great stuff. Cardiology ahead of the curve as always.
Yeah. So bempedoic acid has also been FDA approved since 2020. So it's as opposed to what we were talking about before with those injectables, bempedoic acid is back to being an oral drug. So it's an oral drug. It's first in class. It inhibits the synthesis of cholesterol. So it works in the same pathway that statins work. So statins, are HMG-CoAce reductase inhibitors that block cholesterol synthesis. And bempedoic acid blocks cholesterol synthesis in a step upstream. It inhibits an enzyme called ACL citrase lyase. And so with both, anything that's blocking cholesterol synthesis, the way it lowers LDL is that you block cholesterol synthesis, so the hepatocyte, upregulates LDL receptors, more receptors on the surface of the liver, and then the receptors, clear out circulating LDL from circulation, and so that's how it lowers LDL. Now, these are, bempedoic acid's not as, potent as these monoclonal antibodies, but it's kind of similar to the range of ezetimibe. So in the Clear Harmony and Clear Wisdom trials, as you mentioned, those were on a background of statins, patients with ASCVD or heterozygous FH who had, LDLs still above 70. So this was on statins, and bempedoic acid further lowered LDL by about 18%. But in the Clear Serenity trial, it was patients unable to tolerate statins, and it was slightly greater LDL reduction of 21%. It's also been studied and packaged and also as an option as a fixed dose combination with ezetimibe. So you can get bempedoic acid and ezetimibe, in the same pill, and together that's even more effective, about 36% lowering in LDL. So getting kind of in the range of the moderate to higher intensity statins. So, what are the advantages? Well, one is that bempedoic acid is a prodrug that requires activation, and the enzyme to activate it is only in the liver. It's not in muscle. So it does not have these muscle-associated symptoms that have been reported in statins. And we can talk about whether some of the statin-associated muscle symptoms are nocebo effects or are largely exaggerated. But this drug doesn't have those muscle-associated effects. It doesn't work in muscle. It's very specific to activation of the liver. Another advantage is that it does not seem to worsen glycemia or increase the risk of new onset diabetes. So one thing that we have seen with statins, particularly high-intensity statins, is that there's a small bump in blood glucose. And for patients that are kind of on the pathway there, that already have, pre-diabetes, it can bump the A1C, to a range where they'll not be classified as diabetes. So statins, though, we think that, still the benefit is outweighs this slight increase in glycemia, and that's why we still use statins. But bempedoic acid actually doesn't have that increase in glycemia. It actually seems to be associated with lower risk of diabetes. So that's really interesting. Bempedoic acid also lowers C-reactive protein, which statins do as well. So we know it lowers LDL, and so it did get FDA approved in February 2020 for the treatment of patients with ASCVD, heterozygous FH who require LDL lowering, despite maximally tolerated statins. And, again, a lot of patients, the maximally tolerated dose of statins is 0 statins. And so I'm particularly interested with the lack of muscle effects for patients. This may be a good option. But we don't have the outcome data yet, but we should have that soon because the trial is already finished and starting to close out. So the Clear Outcome trial was examining whether bempedoic acid could reduce major adverse cardiovascular events in patients who were statin intolerant. So it was actually a trial of patients who were intolerant of statins. And what I was excited about is that this trial enrolled nearly half of women participants. So women are, been historically under-enrolled in lipid trials and cardiovascular trials. Usually only 25% of trial participants are women. But in this trial, it's about half participants are women, which is exciting. And I think this is because this is enrolling a population with statin intolerance, and women are more likely than men to report statin-associated muscle symptoms. So, I'm anticipating it's going to be successful. We know it lowers LDL. And to date, all these other therapies that lower LDL have lowered vascular events. So I'm anticipating a positive outcome. We thinking that maybe it might be presented at the American College of Cardiology meeting in 2023. I don't know for sure, but that's sort of the rumor if they can get the data cleared in time. So we may know as early next year about the outcome data. But it is already FDA approved both by itself or in the combination with ezetimibe. So it's a good option for a patient that wants an oral agent.
Now, I saw that there might be some risk of uric acid or gout attacks with this. Like, do I need to be checking uric acid levels in our patients if this is going to be one of those other medicines that I will be using for my statin intolerant patients?
Yeah, so they can elevate uric acid levels. So if you have a patient who has had gout or, that's something to be, mindful of and discuss, with patients for that. It's not necessarily required that you measure uric acid to follow on this therapy if patients, don't have a history of gout. I personally tend to get kind of a baseline level just to see. But the risk is modest. And unless a patient actually has significant episodes of gout, then, that might factor in that decision. And we'll know more from the large outcome trial. So we'll know a lot more about safety.
Was that also creatinine elevation? The source I was reading, it didn't really mention whether it was significant. It just mentioned uric acid and creatinine might be raised, but I don't know if that's something that's been like a major signal out of these other trials and the safety.
No, I mean, the safety has been, pretty good with this, the slight increase in uric acid. And the other thing which was possible, this tendon rupture. It was seen in one of the small trials, and the mechanism for that really isn't clear, and they're wondering if, it was spurious. So we'll really have to see when that reports out in the Clear Outcomes trial.
So to recap here, bempedoic acid, less potent, maybe on the order of what we can expect lowering with ezetimibe, and it can be given for patients maybe if they're statin intolerant or just as add-on therapy. And it also comes, you said, in a combination, like fixed dose combination with ezetimibe. And this, you said the outcomes it's FDA approved, but we're still waiting on these outcomes.
Well, evinacumab right now is only FDA approved in homozygous FH, but there are other agents that are being studied for ANGPTL3. I can briefly, ANGPTL3 is a inhibitor of lipoprotein lipase and endothelial lipase, which is responsible for triglyceride metabolism and HDL respectively. And so we saw from genetic studies that individuals who have loss of function mutations in ANGPTL3 have very low levels of triglycerides and LDL. And why it may particularly be useful in homozygous FH is that the reduction in LDL levels is independent of the LDL receptor. So all those other drugs we were talking about work by upregulating the LDL receptor, but this works independent of the LDL receptor. So that's helpful for homozygous FH because those individuals really don't have any LDL receptors or have very few or ineffective LDL receptors. So this is helpful for that. Now, inhibition of ANGPTL3 is also being studied as a potential therapy for elevated triglycerides. And vupanorsen was an angiotensin oligonucleotide, ASO, targeting ANGPTL3 mRNA. And so earlier this year, the Translate TIMI 70 trial was published that evaluated vupanorsen in patients who had elevated non-HDL and elevated triglyceride despite statin therapy. And vupanorsen, which, again, is an ASO targeting ANGPTL3, did significantly reduce triglycerides by, 40 to 60%, reduced modestly ApoB and modestly reduced LDL. So it lowered non-HDL like it was supposed to, but unfortunately it was associated with increased risk of liver fat and elevated LFTs. So this, led to the announcement that the clinical program for this particular agent is not moving forward. But it does open the door for other investigational therapies, specifically targeting ANGPTL3.
Well, speaking of triglycerides, Chris,
Yes.
What's the last thing we wanted to talk about on the agenda?
Yeah. So say our patient, instead of having LDL of 250, he has a triglyceride of 250. And, I remember back to my residency days when we're using like ATP3 and, our treatment, we're targeting LDLs because we know that triglycerides, we've tried to reduce it with fibrates, but we don't really see the outcomes. So people with high triglycerides, we target their LDL. But since, we've had a couple of new trials, new medications talking about triglyceride lowering, we have the Reduce It trial that talk about icosapent ethyl, and we've we've done it on a couple of hotcakes. We've talked about icosapent ethyl a bunch on the Curbsiders. I was wondering, can you give us a little brief rehash of what icosapent ethyl is? How is it different from like other omega-3 agents, and how does it help us in our management of lipids in our patients?
Great. Yeah. So elevated triglycerides, are a risk-enhancing factor. So, especially for, moderate hypertriglyceridemia, you'd still start with treatment with a statin. And lifestyle is really important. Before we get to these drugs, I want to emphasize that, much more so than LDL, triglycerides are very responsive to, weight loss. Even modest amounts of weight loss can influence triglyceride levels, and, dietary changes, reducing saturated fats, having more of the polyunsaturated fats, reducing simple carbs, reducing alcohol, increasing physical activity. It's all really important for management of elevated triglycerides. So as you mentioned, niacin and fibrates, all of the fibrate trials to date have not shown reduction in reducing ASCVD events on a background of statins. We had held hope for pembafibrate, and it hasn't been published yet, but they announced that the prominent trial of patients with diabetes and elevated triglycerides that was stopped early for futility. So it seems like yet another fibrate was unsuccessful in reducing vascular events. So the REDUCE-IT trial with icosapent ethyl studied patients with ASCVD, diabetes, with another risk factor, who had well-controlled LDLs on statin therapy, but had residual moderate hypertriglyceridemia, 135 to 500. Compared this high-dose EPA at 4 grams a day compared to placebo, and showed a really dramatic 25% reduction in major adverse cardiovascular events. And, we did not see this with other agents that were combined EPA and DHA, notably the STRENGTH trial, which also studied a high dose omega-3 formulation with, did not reduce cardiovascular events. It was really as null as you can get. But this was, combined EPA and DHA. So, EPA and DHA are chemically different. EPA has 20 carbons and 5 double bonds, and DHA has 22 carbons, 6 double bonds. And, that might sound pretty similar, but keep in mind that, estrogen and testosterone are actually very chemically similar, and only modest differences between those two structures, have dramatic, biological effects. So even small chemical differences can influence things. We know that EPA and DHA inserts differently in cell membranes. So EPA being shorter, inserts in cell membranes in a more organized fashion, leading to membrane stability, where DHA is more disorganized. It's longer, it crinkles, so it has more membrane fluidity, and thus leads to more cholesterol aggregation in the cellular membrane. So they are different, and proteomic studies have suggested that EPA may downregulate sort of anti-inflammatory proteins, upregulate anti-inflammatory proteins and downregulate inflammatory proteins. So they do seem to have biological mechanisms. So, it is hard to reconcile STRENGTH and REDUCE-IT, but they are different agents. That we do know, blood levels of EPA matter. It may be that, with EPA, with the 4 grams a day, that you're really getting to these blood levels above 100, that although it may not be influenced by achieved levels of triglycerides, but achieved levels of EPA may matter. And it may be that DHA, offsets some of the benefits of EPA. That I don't think DHA is toxic in of itself, but it may block or, reduce some of the beneficial effects we think of EPA of being anti-inflammatory and antithrombotic.
Did you see there was, I guess it came out, and I can't remember which journal it was, but just talking about the placebo, maybe it wasn't inert. The STRENGTH had like corn oil placebo, and REDUCE-IT used a mineral oil placebo, and that the placebo group in the REDUCE-IT trial actually had an elevation of CRP versus the placebo group in the strength trial had a reduction in CRP. So they were thinking maybe there was some sort of pro-inflammatory effect of the mineral oil placebo and reduced it. And that's why it made the intervention arm with the EPA look better. So I don't know, but that was something that came out. And Chris, is that what you were getting?
Yeah, that was in June.
Yeah.
Just came out in June in circulation, and
Yeah, so this was known to the FDA. I mean, they knew this when this was originally published. I'm really not sure what these biomarker data means exactly. So the reason why they use mineral oil is because they really wanted to have a true placebo that was identical in appearance. So they needed a clear oil that mimicked the oil of the EPA that looked very similar. And that's why that was used for blinding. It was, hard to think that such a small amount, 2 tablespoons a day could really, offset it that much. There has been reviews of other studies that use mineral oil that didn't really find, a clinical relevant effect that, that they, would reduce, cause harm. But, the FDA, this was known that, so the fact that, so in the mineral oil arm, there was a increase in LDL and an increase in CRP that those biomarkers were not affected in the icosapent ethyl treatment arm. And so it's hard to know what that means. So this was available to the FDA and they did, review secondary analysis. They looked at comparing EPA to the control group that did not have an LDL elevation or did not have a CRP elevation and showed that the findings were robust in those sensitivity analyses. So, it's hard to think that, I don't think it's a good thing that the mineral oil raised CRP and LDL slightly. Those certainly, doesn't appear like that's probably not a good thing, but I don't know that could explain away a 25% reduction in major adverse cardiovascular events. I don't think it can explain away all of the results. So maybe the results would not have been that traumatic. 25% is a really big reduction. So maybe if there had not been this, increase in the comparator arm, the mineral oil arm, maybe the effect wouldn't be, as great as was seen. But I don't think that it really could, explain away all of the benefit. But to be honest, we don't really know what it means. We don't know what these elevations of biomarkers necessarily increase risk. That's not proven. How much the CRP bump really, affects the, translation of risk. And so I think that, I take that into account a little bit, but we really, the findings are a little bit uncertain about what this means in terms of interpreting the overall trial results.
So people haven't just completely abandoned icosapent ethyl because of this question. It's still something people may be using in certain select patients.
Yeah. So, of course, LDL lowering is still, the first line. So even in Reduce-It trial, these are all well-treated patients who are on statin. And we're not doing a good job with making, have patients being treated, in the first place with therapies that we know that we work in the, the Gould registry, for example, of patients with ASCVD. 2/3 of patients remained with an LDL above 70. In over a 2-year period, only 17% had their lipid-lowering therapy intensified. So we're not doing a good job with getting to patients, to go with their LDL therapy. So we need to do better about that.
Paul, does this surprise
you?
No.
How are we doing?
But yes, I still use icosapent ethyl in patients who, I do get their LDL down, who have elevated triglycerides, if they're high risk, if they have ASCVD or diabetes and risk factors.
Yeah, I think I'm laughing. I'm laughing at the fact that we're not lowering LDL enough, but it's like we're not even. I think more than half of patients with high blood pressure aren't controlled under 140 over. Even if you look at 140 over 90, not even the 130 over 80. So I think it's just clinical practice is hard. It's hard to get patients to take the medicine. It's hard to overcome inertia sometimes. Adding medication and making changes. Paul, I'm sure you have thoughts on this.
No, I think it's really exciting to have all these agents to be having these conversations. I do think if you're having this discussion, your patients are probably in pretty good shape because I think a lot of the times I can't remember the percentage. I think it's in one of the articles that we reviewed in preparation for this, but like patients with peripheral arterial disease, like so who have known ASCVD, like the percentage that are just not even treated with statin therapy is sort of staggering. So I think your point about just thinking about just being diligent and really using the tools that you have at your disposal before you get too fancy with things is well taken.
But at least we have other agents that we didn't have before. So unfortunately, I encounter, maybe that's because it referred to me, a lot of statin reluctance. There seems to be this bad PR out there about statins, even though we have, hundreds of thousands of patients in clinical trials and overwhelming safety data. But there's this exaggeration of the thought that statins cause muscle damage when really, severe muscle injury is like, 1 in 100,000. It's incredibly rare. And, there was just a paper out in Lancet, again, a meta-analysis, really showing this nocebo effect that, 90% of these, reported statin-associated symptoms, are elicited, by the placebo too, that they're not true drug effects, that they are, if you think something's going to harm you, you're more perceived to have this risk. So patients are being treated with statins, but while we try to, work with them, the statin side effects, the statin associated symptoms, feel real to them, and they, but the good news is that we have things that we can offer them. So, we have bempedoic acid, we have the PCSK9 inhibitors, we have inclisiran, for the higher risk patients. So we have more options and more tools than we ever did before. So we really need to, get patients to goal quicker. So I would just encourage thinking for your very high risk patients, be thinking about combination therapy early and upfront. This sequential approach, takes too long. There's now data showing, benefit of, if you give PCSK9 in the hospital immediately after acute coronary syndrome event, not only is that safe, but, you can show plaque reduction on IVUS. And so be thinking about administering these early and then titrating every 4 to 12 weeks if you're not at goal to be intensifying therapy.
Well, I think that's a great place to end.
She just gave us the take-home points, right?
This has been fantastic. Probably we'll need a part 3 with you once we have outcomes data and for you to help talk us through how these are all being put into practice as we have that data and they become more widely available and widely used. But thank you so much, and can't thank you enough for all the time tonight.
Thanks again for having me.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy?
Oh,
great. Get show notes. I don't know why that one threw me of all the ones we've been doing for 17 years now. Get your show notes at thecurbsiders.com. And while you're there, sign up for our mailing list to get our weekly show notes in your inbox. Plus, twice each month, you'll get our Curbsiders Digest, recapping the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value, practice-changing knowledge. And to do that, we want your feedback. So please subscribe, rate, and review us on Apple Podcasts or on Spotify. You can also send an email to askcurbsiders@gmail.com. That's right, askcurbsiders@gmail.com, Paul. We changed it. And a reminder that this and most episodes are available for free CME through VCU Health at curbsiders.vcuhealth.org. Wanted to give a special thanks to Dr. Chris the Chew Man Chew for writing and producing this episode, and to our whole team. The show is produced and edited by Podpaste. Elizabeth Proto runs our social media. Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
This has been Chris the Chew Man Chew.
And as always, our main Dr. Paul Nelson Williams. Thank you and goodbye.